Okay, my name is Lim Taitian. I'm actually a Dutch citizen. I grew up in the Netherlands. I did my medical school in Amsterdam. I did 5 years of internal medicine training in Amsterdam, became an internist, and then decided to become a cardiologist. So I was supposed to continue with my cardiology fellowship in Amsterdam, but I also applied to a few universities in the US, and I got accepted at Stanford, and I decided to go to Stanford for a few years. And when I was there, of course, a different world opened up to me. Although I must say that the training in Amsterdam, if I may say so, was better than at Stanford. Stanford does have the name. And what was important at Stanford is that not only were we trained in doing procedures, but we were also encouraged to develop ideas and write patents. And if we had an idea and write patents, we could work with the industry or get funding to develop these ideas further. And that was one of the biggest advantages to be in an environment like Stanford, to do creative thinking, to use new technology in your work. So for instance, studying in Europe is very good. We have both, we both get trained in clinical medicine, but also to do research. In the US, it's not only clinical medicine and research, but also see if we can try to monetize that. So after Stanford, I came to Singapore. I had 2 job offers from Singapore, both from the National Heart Center and the university. And since I was still interested in research, I chose to work at the university. I had grants where I did my research in stent coatings at the time. And after 4 years, I decided to move to the National Heart Center, where I worked for 5 years. And then afterwards, I went to private practice, and I've been there since then. So every phase in your career has different aspects, meaning, and in those who want to study medicine, you have to go through these phases and decide what you want to do. Yeah, I mean, when I did my training in internal medicine, it was very tough, but I learned a lot. Being more creative and try to do something useful in technology, and develop stent coatings and putting them in animals was very exciting, especially in those days. Putting in stents in coronary arteries was a new thing, but there was one big problem, and that was scar tissue formation inside the stent. And that's why we developed stent coatings. And of course, private practice is a totally different ballgame. There you focus mainly on the patient. You do complex cases, you work with other specialists together, and you try to apply new technology for the patient in a practical setting. But to learn how to use these basic techniques, that one you need to learn in your training, and that one you need to learn in an institution like the university or the National Heart Center. Yeah, I mean, I saw your questions, and one of the questions you raised is is there any new technology you want to incorporate? We can get back to that later. I think medicine is evolving all the time. And yes, you need to be on the lookout for new technology, but you need to be trained in a certain specialty and subspecialty in order to apply the technology. I hope that answers your question. I think different phase in life. When you're young, you're very ambitious. You want to do the good things for the institution, also for yourself, let's say academically. But like working in either corporate or an institution, there are always a lot of politics involved, meaning you have to work with other people who want to try to block you, and unfortunately that's the reality in life. Of course, as a student, where you have not been exposed in life, you think everything is hunky-dory, but in real life, you will face hurdles and you will face obstacles. And I think it was more of a push factor than that private practice really was a preference for me. For me, the push factor was that a lot of my projects got blocked because of politics. So it was a push factor to go out. But I'm happy that there was this push factor, because otherwise I would have never experienced private practice. And coming out to private practice, I think it was one of the best things, one of the best decisions in my life, because you work independent, you only have to answer to yourself, and it's the patients who are happy with you. And that's how you build up your practice. You treat your patients well, you give the right diagnosis and the right advice, and you do a good job in your procedures. Patients recognize that and will come back to you. It's very different working in an institution where you see so many patients that patients become a number and you don't have the time to spend time with them. So again, for me, the independence is very important. The other thing is, we can still develop new technology. In the early days of my private practice, with the money I made, I actually invested in my own research. I bought lab animals. I did my experiments still at the National Heart Center, but I didn't need to depend on funding from the institution. I could work freely with industry to develop stent coatings. But of course, when my practice got busier, I didn't have time for that. But now I have other objectives. I mean, I have a busy practice. I work together with other specialists. I mean, I saw the questions you wanted to ask me. I mean, one of the questions you wanted to ask me is how do you see in the coming years how technology will influence your practice? So as a cardiologist, I work closely together with cardiac surgeons. And also cardiac surgeons, they will develop. And one of the new things in cardiac surgery is what we call minimally invasive surgery. So normally when a patient needs to repair a valve or change a valve or have bypass surgery, the surgeon needs to open up the chest through the sternum. I mean, you've all seen the scars on the sternum of somebody who had open heart surgery. But can you imagine you can do that surgery now through a 2-centimeter incision in between the ribs? So I worked together with one cardiac surgeon who was the former head of cardiothoracic surgery at the university. And he's a pioneer in this field. He was also at Stanford. He gets invited all over the world to demonstrate his techniques and to operate minimally invasive. So this is a field which is at the beginning, although it has been around for 10 years, but let's say in Asia, there are probably less than 5 surgeons who can do this. And he's one of them in this region. And I think the exciting part is, since he also came out of private practice, that here in Mount Elizabeth, we tried to set up a minimally invasive cardiac surgery center and develop that more. When you can open up arteries using a balloon, and you do that through a catheter which you either insert from the hand or from an artery in your leg. And what you do is, if there's a blockage, you balloon it. And before the era of the stents, we would just balloon it, but often the artery would close again. Then someone had a smart idea in the early 90s to develop a stent. So the first generation of stents were bulky and difficult to pass into an artery. And although the initial result looked very good, about 40% of these stents developed scar tissue, meaning after 4 months, 40% of the stents would be blocked again, and you had to repeat the procedure. So if you talk about technology, what happened was we tried to find a way to inhibit the scar tissue formation. It's just like if you cut yourself, some people develop a keloid on their skin, a thick scar. So the same happens in an artery when you put in a stent. The body reacts and you get scar tissue. By developing a biodegradable coating, you can put in drugs there which can inhibit the scar tissue formation. So in the early days, people put on drugs on stent, but it was with a coating which didn't dissolve. And I worked on a coating which would dissolve, meaning after 3 months or after 6 months, the coating would be gone and the drug would be released in a time-release manner, meaning over the period of 3 months or 4 months or 6 months, you could design it like that. So my research was based on that and my experiments were based on that. I hope that answers your question.
So,
our analysis of scans, for instance, we can use AI in when we analyze problems in patients by asking them questions, and we can use AI when we look at angiograms and try to see what is the best method to treat that patient, either with bypass surgery or stenting or a combination, because it's all about numbers. What is the best treatment method for this? Will AI replace the doctor? No. But will AI help in the decision making of a doctor? Yes. Can AI speed up the patient care, the efficiency of the patient care? Yes, definitely. What you also need to realize about medicine, there's a lot of paperwork involved, meaning recording of medical reports, dealing with insurance companies, etc., which we doctors, all of us don't like. So AI can help in that, meaning can already prepare a medical report based on the notes we made. Yeah. So AI will make a difference. Now, robotics, it's I think it's a little bit overhyped. What you need to realize, let's say, about robotics in cardiac surgery, you still need a surgeon to operate a robot. It's not that the robot will operate itself. You understand? So robotic surgery for a cardiothoracic surgeon is to use a machine, what we call the Da Vinci robotic surgery arm, and basically it can help with making the surgery smoother. At this present moment, robotic surgery is much more developed in other types of surgery, like in gynecology or prostate surgery, where you need to reach a space which is difficult to reach, and that's where robotic surgery comes in. Robotic surgery in cardiac surgery, at this point in time, there are few centers in the world who do it, but is there a real advantage of using robotic surgery now compared to conventional surgery? I think the jury is still out there. I don't think so. However, I think minimally invasive surgery, where you operate through a small tube, through a small scope, that's going to be developed over the years, and most of 95% of the surgeons are not trained in that yet, but that may change in 5 to 10 years to come. For instance, my colleague, who's the cardiac surgeon, Dr. Covidis, he has been trained in minimally invasive surgery for over 10-15 years when he was at Stanford. And you need that basics training in order to get better at it and to develop your own techniques. So if you are not trained in it, you can't use it. And like what is typical in medicine, those people who are not trained in it, they will tell others, oh, don't go for this minimally invasive surgery because it's not good. No, it's good, but if you can't do it, of course you say it's no good. So that's what I call evolution and using technology in medicine. That's a very good question and a very sensitive question. This is a very difficult topic, and it's interesting. The Singapore Medical Association has made it compulsory for us now to follow lectures on ethics and how we can implement it. I mean, ethics already occurs with simple things like informed consent. When you ask, a patient to do a procedure, in the old days, the professor would say, I just did a surgery, we will not explain everything. Now you need to explain every single detail and every single complication. I think it's also the same if you make a decision to use new drugs, which have been approved, but a lot of times we don't know the long-term effects, and you need to talk to the patients. Yeah. So we need to be aware of a number of principles, and like you're going to school and you're learning about it, we have to follow lectures and see if we can implement it. No, I think it's a natural process. When students are going to medical school, they automatically will learn about technology, how it's incorporated. It's part of the training. And of course, those students have a keener interest. They will do research, meaning they will join a group who's got an interest in certain research. If it's either medical device related, if it's clinical trial related, if it's molecular biology related, they want to go in that direction. And for instance, in many of the medical schools in Europe, it's encouraged to get your PhD first after medical school before you enter a training program. Here in Singapore, it's very clinically orientated. You don't need to have a PhD first in order to become a doctor, to enter a training program. Although in Singapore, there's a program now between Duke and NUS where they encourage medical students to do research and have that as part of your curriculum. In Europe, it's already quite standard. In the US, if you want to enter the good medical schools and you want to enter a good training program, it is imperative to do research during your medical school years to get publications. Otherwise, you can't get into a good training program. So depending on where you are, research using technology is part of your upbringing in medicine. Okay, first of all, nobody knows if they will like medicine or not. I didn't know. But if you choose medicine, I think, follow the classes, go and follow some doctors in practice and see what you like. And again, if you want to work in a certain field, let's say you want to become a cardiologist. From the time that you're a medical student, it is important to show interest and to do research by joining a group, let's say in cardiology, who does research in a certain field, and earn your credits, and be active in that field. If your objective is, I just want to make a good living, I think there are other professions which you can do. I think the main objective of studying medicine is you must have an interest. And you can't immediately say, I want to go to private practice, because you don't know how private practice is. I think what is most important is your decision. Do you want to be a general practitioner or do you want to be a specialist? And then, do I want to be a proceduralist, meaning do I want to do procedures, or do I want to be more like an internist or a neurologist who does the thinking? Yeah. So you have to make that decision. And then eventually people will have an idea when they work, let's say in a hospital, if they want to come out to private practice. But if that's your objective, to come out to private practice, I think it's the wrong objective. I think your first objective should be just study medicine and see how it goes. If your first objective is to earn a lot of money, perhaps you shouldn't study medicine. Yeah, become an investment banker or whatever. No, in medical school itself, it's your lecturers, your professors, who will initiate the first interest and will tell you, okay, you should read up on this and this. And believe me, during your first year in medical schools, you're swamped with reading your textbooks already. you don't have any time to read anything else. And then later on, when you have your basis, of course, you start to have interest in certain fields. But in the first few years, you can hardly keep up in what you have to study. And it's your lectures, it's your professors which will inspire you to do more. So having a good mentor, having a good professor is very important. Oh, I think in medicine it has evolved very, very fast. And let's give an example of, let's say, an oncologist. So in the past, if you had cancer, you would go to one oncologist and he would know everything. He would treat breast cancer, prostate cancer, lung cancer, colon cancer, liver cancer. You just go to an oncologist. But because of technology, because of the evolvement of biotechnology, because of the evolution of targeted drugs for certain diseases, so-called almost custom-made drugs, biologicals, targeting a certain receptor, it is almost impossible to keep up to date with all the new developments. So if you see an oncologist, or let's say one of your parents sees an oncologist, you better see an oncologist who specializes in that field, let's say breast, or lung, or liver, or colon, because they are the ones who are up to date and they can give a combination of standard chemotherapy and new life-saving drugs. So that's the impact of technology. And things just happen so fast. For myself, I mean, in the old days, a cardiologist can do everything. You know, they do the echo, they do the angiogram, they put in a pacemaker, etc. Yes, I'm still a general cardiologist and I diagnose everything, but I focus on my interventions, open up arteries, making decisions, using different types of devices. But although technically I can put in a pacemaker, would I do that? No, because somebody else can do it better, more up to date because of technology. So technology, you will learn again when you're being trained in a certain field, and you will keep up on it, because otherwise you're out of business. So it's part of your training.